collaborators, and to discuss future agendas to help shape the landscape of primary healthcare and equity. It's lovely to see so many people in the room, live people, three-dimensional people, but welcome also to everyone who is joining us online today. So today we're meeting on the unceded lands of the Bidjigal people. I'd like to pay my respects to elders both past and present and extend that respect to all Aboriginal and Torres Strait Islander colleagues and guests who are present here today. Thank you for being here. I look forward to sharing this experience with you all. I'd like to now introduce Auntie Lola, who will welcome us to country. Auntie Lola is from the La Perouse Aboriginal community, located on the northern side of Botany Bay. Lola is an Aboriginal health worker for the Child and Family Health Team of Sydney Children's Hospital Network Randwick, just across the road, a position that she has held for 18 years. Her passion is improving the health outcomes for Aboriginal families and children and working on projects that can make a difference in engaging Aboriginal families to take care of their health and well-being as well as their family needs. She's a devoted mum to 3 kids and loves spending her spare time with her family and 2 grandchildren. Please join me in welcoming Auntie Lola.
Thank you. Nagami, Naganani Lola, Nai Darrell Gully, Nurnang, Nulamanang, Nai Bidjigal, Yamaringai, Darrell Langa. Welcome, my name is Auntie Lola. I'm a Darrell elder, and I acknowledge that we are meeting on the land of the Bidjigal. And I introduce myself in our Darrell language, the language we are studying to bring back to our community, which was lost, dispossessed, however you would like to put it, when our people were moved on to the La Perouse Aboriginal Reserve many years ago. I would like to pay my respects to elders past, present and emerging and extend that respect to all of you who are present here today. And thank you for inviting me. It's a pleasure to welcome you all to the CPHCE Annual Forum 2023. And, you know, I get involved in, I've been in the job for almost 20 years now, and I get involved in quite a fair bit of research things. But my great passion at the moment is healthy housing and healthy living for our people. So I've been involved in that research project for 4 years now. And we did present in Melbourne last year. And next year we will be presenting in New Zealand. So it's something that I think we need for our families to grow up strong and healthy, especially our wonderful children. Our welcome to country was traditionally performed through song, dance and music to welcome other tribes to our land, as there are hundreds of different language groups in Aboriginal Australia. Today we welcome you in a contemporary way and ask that you respect the land, our culture and traditions. We always thank our ancestors for caring for our land, our oceans and our waterways, as they only took what they needed to survive. That way, no family went hungry. Our people walked the land seasonally from the Sydney Harbour to the Shoalhaven region to sustain the wildlife and the vegetation. That is how we survived for over 65,000 years. And we live in such a beautiful country. Sharing our traditional cultural knowledge and stories with the wider community enhances that Australia has a strong Aboriginal history. On behalf of my ancestors, my community, I wish you all a very warm welcome. And the spiritual people, we believe our ancestors walk with us. So may their spirits be with you, keep you safe wherever you may travel to or from. Gudjuri, Nandawabi. Thank you. Have a great day. Thank you.
Thank you very much, Auntie Lola. Now, before we go on, just a few housekeeping notes for today. Please put your phones on silence. If you need to take a call, just pop outside. Please be with us if we experience any technical glitches, but we're planning on everything being seamless and smooth today. So today's theme is centred around the changing and sometimes challenging landscape of primary healthcare and equity. Some say we're living in a time of perma-crisis, post-COVID blues, climate change, interest rates, cost of living stress, and recent events really showing there's major differences in what people think the right thing is to do. And we know that all of those have uneven impacts. So health equity is a matter of social justice. It's a central theme that cuts across everything we do at CPHCE. The work we do at the Centre in partnership with you involves addressing not only the inequities caused by these challenges, but also the socially determined causes of health inequities. So our work requires transforming systems and structures. And the Centre's been instrumental in doing that over the years, and we're excited to showcase some of the work today during the forum. We've got a pretty big program, so big in fact that we've split it into 2 sessions. The first session you'll hear from Margot Barr and Freddie Cetus giving us a sort of showcase of what we've been doing this year. And then we'll have the Ian Webster oration, and we'll break for morning tea. We've got a decent amount of time for morning tea today because we know a big part of today is just us spending time together. And during that tea break, we'll also be taking photos. So when we come back after morning tea, we'll begin session 2. We're going to hear from a range of people and organisational perspectives on the changing and sometimes challenging landscape of primary healthcare and equity-focused research. So there'll be presentations, Q&A sessions, discussion panels, and of course, awards. So let's begin. Please welcome Associate Professor Margot Barr, Acting Executive Director of the Centre, and Freddie Cetus, Director of the Centre for Primary Healthcare and Equity, to kick off our presentations for today.
We need to go to the next slide. So Freddie and I are here as a joint team because, as people are aware, Mark retired at mid-year, and so the 2 of us have taken over holding the fort for the centre on our transition to a new director. So we're going to take it in turns to work through to talk about some of our achievements for 2022 and also some of the achievements for 23. And a lot of it is summarised in our annual report, which is online, and also there are some copies out the front that people can see. So some of the sort of early achievements, some of the early things to talk about is around this. A lot of staff completed their COVID-19 secondments in mid-2022. It seems a long time ago now, but people were coming back and focusing back in their university work. We also got the centre review approved for another 3 years, and we got our infrastructure funding from the New South Ministry of Health for another 4 years. We've been exploring research partnership opportunities with Murrumbidgee Health Service, and we have someone from Murrumbidgee here today. And also, as I said, Mark retired in 2023, and we started sort of the search for the new exec director. And one of the things we did for that was developing a sort of a bit of a promotional video. So I'd like to, we're going to show the video now, and then Freddie and I'll talk a little bit more about our achievements. I don't know how to make it happen. The man at the back does. Okay, we'll just move to the side. Is the sound? I see some familiar faces as well. I'm sure we've watched that. Yeah. Be optimistic. No answer, no. That's right. Do you want to move on? I just do. Yeah. Sorry about that. They'll get the sound going. So our mission has remained to create better, fairer health and healthcare in the community. And some of our initial, next slide, please. So Freddie's just going to talk about some of the achievements.
Yeah, these are just some of them. We're just highlighting some of the tremendous achievements that have occurred over the last year with by the team in collaboration with our lovely partners in Southeast Sydney. Yeah. Is that what?
This one, sorry.
Okay.
We didn't know.
All right. So this has been in collaboration with our partners at Southeast Sydney, and Southwest Sydney Local Health District, and we're very grateful for the long-term relationship we've had with the three local health districts and beyond. But just as an example, you know, the Community Health Navigator Forum, the minute you put your hand up on a gap, people come out of the woodwork, and we discovered that there's many job descriptions that resemble a community health worker, but they're not quite that. And so there's a gap in training, accreditation, and identifying places where to put community health workers going forward. We're having an upcoming forum, and on the 8th of November, please attend that. It's following on work that we had. We had presentations from international speakers last year, and we're going to be continuing on this theme. Some of the work that we've done on community health workers using Sydney Local Health District as a demonstration, you know, working out a way to go forward. With regard to the Shisha No Thanks, just a reminder that every Shisha session of 45 minutes is the equivalent of 100 cigarettes, okay? I'm going to stop there in terms of the relevance of that and the importance of doing that kind of work in the appropriate communities. And that's driven by the Ministry of Health and also Cancer Institute and Southeast Sydney, the Health District, Southwest and Sydney. The Miller survey, that's been going on since 1999. Miller has been one of the poorest suburbs in New South Wales. 2068 is the postcode. And that's the 5th round of surveys with regard to looking at access to services and accessibility. And so we've got longitudinal data going, not longitudinal, but cross-sectional data in 5 different surveys across different points in time. And that's linked to the Community 2168 project, which is a major community renewal and capacity building partnership that aims to bring residents, businesses, and government and together to improve services and facilities in that region. Some of our illustrious PhD and postdocs, Esther Alun, I think she's here with us today. She might not be, you know, runner-up for finalists in the category of advocacy and leadership in the Australian Public Health Association conference, and Kath Thorburn recognised as by the New South Wales Mental Health Commission as an activist, reformer, and leader in mental health. These are just the 2 of many illustrious people in the district. And I'll stop there, but we have many other accolades that we won't get into. They're in our report and on our website.
Okay, let's see if we can do that. Oh, wrong way. So Freddie's just going to talk very briefly on this one. I'm going to stop him from talking.
Now this has got lots of papers. About 20% of those papers are together with the local health district colleagues. If you take out all our adjuncts, about half the papers that we wrote are with collaborators in the local health districts. I'll stop there.
So this is also a little bit around, you know, some of the other things we've had. We've had some visiting academics, Julian Forbath and Alexander Labelle, one from Laval University and one from the University of Geneva, various events, our Equity Fest, and also we had various grant applications and awards that have been given. And so the top one has Patrick in it, and the bottom one with Ari, with an award that was awarded 146,000 from the Newcastle Permanent Charitable Foundation for Women's Empowerment and Cultural Resilience Project. So it's just great to celebrate the work that people have been doing, and also the launch of the Working Together Collaboration for Health, which was done by Marilyn Wise and Liz Harris. And so again, the picture in the bottom corner. We've had some PhD completions as well, and some celebrations around that. So the lounge has become our second home for celebrating getting PhDs. One of our PhD students there, Vera, was abroad when she submitted, and so it's also nice. We like to get a picture as people are submitting and moving forward. And our staff days and training is very important to us as well. Quite a few staff have also been overseas for conference presentations, and we had quite a few at the Public Health Congress in Italy recently. So I think with regard to our research and impacts, we've spent a bit of time this year changing our website, so we're better reflecting what we've been doing across both our research areas and our streams, and spending more time working collaboratively in the streams and particularly working with a lot of our early career researchers to think about the ways that they can work on their research, building on the research that we've already done. We've also started providing summaries about previous work and their impacts on them, and with some of the first ones looking at the Community Star. We've also got one on advanced care planning, another one looking at health literacy. And so, rather than just having projects that are finished, we're then reflecting on the work that's happened in those projects and the types of impacts that they've had. I think I'm handing to you now, Freddie, to talk a little bit about our collaborations. And then we'll see if we can have the video, if it will work with sound. Otherwise, we'll do it after morning tea. Oh, okay.
You do that one, yeah.
All right, this is very collaborative. So, of course, we've got our collaborations. And as Freddie said, and also as Fiona said, our work wouldn't work without the collaborations with the local health districts and the primary health networks. And our main collaborations are Shetra, Purdue, and more recently we've changed CESPATCH, or the community, the primary and community health cohort resource, from a project to a collaboration because there's a program of work that's being done under it. And so it's a really important collaboration to us that involves the Sydney Local Health District, South East Sydney, and the Central and Eastern Sydney Primary Health Network. So some of our changes and things that have been happening, in Shetra, there was a bit of quite a period of transition with Evelyn retiring and Patrick transitioning into that position. But the work has still included a lot of, their focus on refugee access to health services, evaluations for health and housing partnership, and various evaluation collaborations with council. So the work's still been going ahead, although, these transitions can be challenging sometimes. Purdue's continued building on their ongoing work with engagement with Sydney Local Health District and participating in other research projects, service development, partnerships and education. And some of the COVID recovery work and the HIA has been really important to strengthen what's happening in the area. And of course, a lot of their work on intersectoral action in equity, which I've been involved with quite a few of those projects with Purdue, and some of the work in the Waterloo area has been really, really insightful and rewarding. Of course, CESPATCH was initially set up to inform joined up primary and community self-planning and program development. And there are lots of projects that over time, we've looked at carers, social isolation, telehealth. We've been looking at all-cause mortality and cardiovascular disease. And we have to pay a license fee for that each year. When we started, we were paying $15,000 in license fees because that was just for one person. My last license fee was for $140,000. So that reflects the number of people who now have licenses using that resource, not only within CPHCE, but also the local health districts and the School of Population Health. So I think it really is a resource that we're all using now. And more recently, we've also been using the Lumos resource. Right? So Freddie will talk about our challenges and opportunities.
The centre's been functioning business as usual as much as possible. We Mark's retired, and he's been very gracious and leaving us in our own resources and to get on. He still assists here and there, which is fantastic. But I guess our challenges are going forward. It's we've got a review underway at the moment, which we will take on board, and we need to answer to that to the university. Finding the right person is always a challenge, and there's been interviews and shortlists and things like that. So we look forward to seeing what happens there. And I don't think there's any further challenges that this kind of, I think you'll see from the presentations going forward that this kind of work is slow, deliberate, and difficult. And so one of the challenges is how do we do this smarter, faster, and more effectively. And so that's one thing from my perspective as a researcher. Now, how do we get the same outcomes or better outcomes without the difficulties of working in a health system that is under a lot of stress at the moment? So yeah.
So just to finish, we know it's not an easy path, and I think the image of the road going through the landscape that isn't always an easy landscape, but we know what we do makes a difference, and we've got a good mentor in Mark, and we'll now hand over to Mark, who will do the Ian Webster Health for All oration. So I won't introduce you, Mark, because you'll be introducing yourself as part of your oration, unless we can watch the video first. No, okay. Mark, we'll hand over to you. So, Mark's done a wonderful job over the years.
Thanks very much. Thank you all. I'll talk a little bit about history, some of which you won't know, and hopefully not bore you too much. One of my colleagues was a bit astonished by the fact that I was going to talk for 40 minutes or 45 minutes or something. I thought that I should have a break in the middle so you can all wake up and stand up or something. So I hope that we don't need that, but we can always do that. So I'm a little bit optically challenged because I left my glasses on home, naturally. So these are magnifiers, so I'll try and cope. So I'd like to start, thanks very much for inviting me to give this talk. I'd like to start by acknowledging the traditional owners of the land that we're all meeting on, the Eora people of the Bidjigal people of the Eora Nation, and pay my respects to Aboriginal leaders past, present and emerging, and acknowledge any Aboriginal and Torres Strait Islander people here today. I'm also very honoured to give this year's Ian Webster oration, particularly with Ian in the audience, as he often is at these forums. Ian's been a mentor and a role model throughout my career, and I worked with Ian in the School of Community Medicine while finishing my doctorate, then later in Southwest Sydney, and more recently he's he was chair of the advisory committee for the centre for many years since its inception. Ian's got a strong commitment to health equity, and Liz and I have worked with him on many issues over the years, including the health of homeless people, unemployment, refugee health, and so on. And I want to acknowledge the great debt that we both have to Ian in our careers and our work. In this talk, I'd like to provide a thumbnail sketch of the Australian primary healthcare and its relevance to health equity. The name of our centre is the Centre for Primary Healthcare and Equity, and so I want to talk about that, especially as I've found it both in my work as a GP and through the research conducted by myself and others with me. Throughout my career, there's been a connection between observations in my clinical work, conducting research that describes problems, co-designing new approaches with communities and consumers, trialing them in real-world settings, and translating them back into practice and policy and so on. And I'll illustrate this throughout this talk. I'll try and distill some lessons, both for strategies for improvement and further research. I'm going to talk a little bit about my own journey. My own interest in primary healthcare developed while I was in medical school at the University of Sydney. I was involved in community action movements in inner Sydney and felt strong commitment to social justice and addressing disadvantage. During that medical training, I did elective placement in Indonesia, in Surabaya, and I saw the direct connection between social disadvantage and the work in the clinic and the work in the hospital. After my first 2 years as an intern and then medical officer, Liz and I went as volunteers to North Borneo. Liz had been previously in Papua New Guinea, and so we went back to being Australian volunteers in Sabah in North Borneo, where I saw firsthand the health problems of refugees and remote settlements, and also learnt for the first many times the futility of fly-in, fly-out care. In this case, it was fly-in, fly-out to remote communities by helicopter. A complete waste of time. In 1978, the Alma Ata Declaration promoted primary healthcare as a way of achieving health equity, not only through access to healthcare, but by taking action to address the underlying causes, social, economic, and political causes. It saw primary healthcare addressing the main health problems in the community, providing promotive, preventive, curative, and rehabilitative services, bringing healthcare as close as possible to where people live and work, and promoting maximum community and individual participation. I saw a career in general practice as responding more comprehensively to people's needs in the community than the alternative. After completing my GP training, I began my career as a GP in Bourke, which, for those of you who don't know, is a small town about 800 kilometres northwest of Sydney. This was a formative experience for me, giving me great insight into the importance of Aboriginal culture and its contribution to Australia. And during this, I conducted research on the transition in Aboriginal health that occurred from the 1970s to the 1980s. There had been previous people, GPs in Bourke, Max Camion and Teddy Cooligan, who'd documented this in some of their own work. And I again saw the social determinants of Aboriginal health inequities and the potential contribution that primary healthcare could make in helping to address these. The importance of primary healthcare as a level of care and approach was reinforced when we worked again for 2 years in the public health system in Vanuatu, which many of you might think is a great place to be. It is. You probably may have been there on holidays, but it's also got significant health problems. It was at that stage still in the grip of infectious diseases. 100% of the population in some areas of Vanuatu at that time had malaria, had people succumbing to malaria each year. And this was, but it was starting to see the emergence of chronic disease at the same time. And to understand the need to develop a more robust primary healthcare system. Later in southwest Sydney, where I established an academic general practice unit with Bob Fisher, I was exposed to its culturally diverse population and its equally culturally diverse GP population, and with whom we embarked on establishing some of the first local primary health care organisations, the progenitors to our current primary care networks. Finally, in 2000, I moved to UNSW campus and began clinical work as a volunteer at the Sydney Asylum Seeker Centre, seeing people who didn't have access to Medicare or the other parts of the health system. So you can't discuss primary healthcare inequity and not talk about Barbara Starfield. Barbara was a champion of the value and need for a strong primary health care. Her research demonstrated clearly for the first time on the international stage that good primary care was associated with better outcomes, lower costs, and greater health equity. She articulated 4 functional characteristics: access, comprehensiveness, continuity, and coordination. Later, she added participation. Her research helped me answer a question that kept being put to me by specialist colleagues after my appointment as Foundation Professor of General Practice at UNSW. The question was, what does a Professor of General Practice do? Isn't general practice just the easy bits of all the specialties? And that obviously reflected a deep skepticism, which fortunately there's less of now, of the value of primary health care. But more importantly, it helped me to think about the potential, Barbara's work helped me to think about the potential contribution that primary health care could make to health systems and the health of the population, including health equity. I'd like to expand briefly, probably too long, sorry, some of you who are probably wanting me to end this talk. I'd like to expand briefly on each of the core functions proposed by Starfield and analyse the performance of Australian healthcare and its implications for equity. So the first, of course, is access. And Starfield's original work focused on just the distribution, the availability of primary care, and showed that it was associated with lower mortality, better health outcomes. Of course, this is a very limited model of access. We needed at that time a broader view of access that could encompass it being more approachable, accommodating to language and culture, responsive to health literacy, and so on. But also, and importantly, the other side of the equation, yeah, it does work, the consumer side, the ability of consumers to perceive their need to seek, to reach, and afford and engage with healthcare. We articulated this in what's become known as the Levesque model because the paper was led by Jean-Fred Levesque, who will be known to many of you, who at that time was in Canada, and has been very widely cited and used as a framework for assessing services and designing interventions. So how are we going in Australia? A quarter of Australians over 45 reported needing to see a GP, but not going. And 50% of those were because they couldn't get an appointment. This is in 2016 international survey. And this is like a universal health insurance system, Medicare, which suggests that we perform poorly in terms of affordability due to co-payments compared to many other countries that we compare ourselves. Perhaps not the United States, but many others. A quarter of adults experience difficulties accessing primary care out of hours, which was higher than many other countries. And this has led to a variety of fragmented strategies over the ensuing decades, including establishing GP after hours services and the current moves to establish urgent care centres in order to reduce demand. In 1971, Julian Tudor Hart wrote a paper in which he described the inverse care law as he saw it in general practice, in his general practice in Wales at the time. And this was that the key message was that he saw evidence for the availability of good medical care tending to vary inversely with need. Now, there is some evidence to support this, unfortunately, in Australia. There are differences in workforce availability and uptake of preventive care across 3 groups, as you can see in this table. Aboriginal and Torres Strait Islander people compared with non-Aboriginal people, remote and very remote, people living in remote and very remote areas compared to major cities, and the lowest and highest socioeconomic status. And ratios for general practice and co-payments differ, with lower co-payments and higher level of use in Aboriginal and Torres Strait Islander people compared to other Australians. The patterns reversed in remote areas, partly due to the higher rates of co-payments, which GPs use as a means to reduce some of the demand and workload. Although they tend to have lower co-payments, Aboriginal and Torres Strait Islander people are more likely to forgo or delay treatment because of cost. And this reflects their own ability to pay. And this accords with my own clinical experience in rural and Aboriginal communities and in low socioeconomic areas in southwest Sydney. I observed even more extreme barriers to access to primary care by asylum seekers who weren't covered by Medicare. This resulted in poorer outcomes, including disability and death, especially prior to relaxation of access barriers by state health services. So you may not realise, but I think it's now about 12 years ago, the state government relaxed its restrictions on access to hospital services for people who were bona fide asylum seekers. Prior to that time, they were confronted with signs like this. This is a sign from Prince of Wales. It wasn't alone. There were many hospitals that had signs up like this in the ED department, and meant that people had to pay large amounts of money if they presented for emergency problems. For example, there was one child who broke his arm and presented to the emergency department, wound up with a bill for $1,500, which of course they couldn't pay at that time. So, of course, an additional barrier faced by refugees and migrants is language. While bilingual GPs address this to some extent, and we're very fortunate to have so many GPs around Australia who speak languages other than English and can converse directly in the language that their patients speak, this doesn't apply to the services that they refer to. Estimates of the level of interpreter use in general practice are less than 10% of the consultations where it was needed. And this is largely because of the availability of time to using an interpreter. I use an interpreter in my clinical practice, which I still do. Still haven't quite retired from that yet. And a telephone interpreter, and it doubles the time, at least, that it takes to conduct a normal consultation. So primary healthcare workforce is predicted to get worse over the next decade, and these will impact most in low socioeconomic areas and rural areas. Ultimately, the funding system needs to provide greater incentives for higher value care, such as longer consultations or preventive care for those most in need. An example of this was the provision of psychological services by primary care networks, where they prioritise vulnerable and disadvantaged patients. And this was in contrast to the Medicare payments for better access to mental health, which have showed a strong social gradient with people from higher socioeconomic groups tending to uptake those services. I better go move on. The next idea is comprehensiveness, and this refers to the extent to which primary care can address the needs of the population they serve. And this links to the three dimensions of coverage that WHO talks about. This is a diagram from WHO. And so in addition, when we think about coverage, particularly financial coverage for people to be able to receive care, it's not just about who is covered, which population, and what proportion of service costs are covered, but also the range of services. And these were extended really importantly in this country, and it's something that the Canadians are envious of, in 2006 through the introduction of multidisciplinary team care arrangements that at least provided some access to allied health as part of the public health system, a part of Medicare. Arrangements and funding, this was particularly for people with long-term conditions. The provision of multidisciplinary primary care has improved over the last 2 decades, with increasing coverage of allied health and psychological services through Medicare. And these have contributed to reduced demand on hospitals, especially for patients with long-term conditions. However, there have been significant limitations both in the range of services that are covered and in the number of services that are available under the plans. Also, teamwork's more challenging to achieve in the Australian system because allied health are largely not co-located in general practice. There's some co-location, but it's quite limited. It's also influenced by context, including the size of the practice. Smaller practices actually are able to create more effective teams than larger practices. And this was an important lesson that we confirmed in the evaluation of multidisciplinary super clinics. The Commonwealth had a program called Super Clinics, which was about creating large multidisciplinary primary care services, and there are a number funded. But the focus was on putting people in the building. There wasn't a focus on actually creating teams. And creating teams requires a lot more than that. It requires communication, shared goals, and leadership. Prevention's a key aspect of comprehensively and proactively dealing with patients' current and future needs. The key framework supporting preventive care is the 5 A's in this diagram. And the important thing about this is not so much what it says, which is about ask, assess, advise, agree, or assist and arrange, but allowing activities to be implemented across time and across different members of the team, as well as linking to external programs and resources. We've shown this to be associated with a greater likelihood of change in the behavioural risk factors especially, and is now incorporated into many guidelines. Prevention is now an accepted central function of primary care, contributing to immunisation, particularly recently. Michael in the room, the COVID pandemic demonstrated the contribution that primary care could make in that. But are the other risk factors as well. And this contrasts to the 1980s. I was involved in the first of the preventive guidelines for general practice that was produced in the 1980s, the so-called Red Book. And when that was published, the Commonwealth government quickly wrote a letter to the college saying, please desist. Prevention is not part of Medicare. So we've come a long way. And that change is partly due to our work and research, but of course due to a lot of promotion by organisations like the College and Heart and Stroke and Cancer Foundation over the past 3 decades. What about health equity in relation to prevention? Dealing with people's needs comprehensively requires time in primary care, especially where there are language or communication challenges. And we demonstrated this fairly complicated graph simply shows that in urban low socioeconomic areas, although people were using GPs quite a lot, GPs provided shorter consultations to cope with their workload and the lower remuneration they received because they were restricted to bulk billing and weren't able to achieve income through co-payments. And this obviously reduced their ability to assess people's needs and provide preventive care. Being responsive to disadvantage and low health literacy requires more time, and systems change at the organisational level. It also requires workforce and information systems and communication. These may be in short supply in many disadvantaged areas. While we've shown that multidisciplinary team care plans, and this is the work that Margot has done particularly, are used appropriately to address complex needs, low socioeconomic groups of people with chronic disease and low socioeconomic groups, some vulnerable groups, such as those with severe mental illness, are likely to miss out again. Advantaged Australians are more likely to use medical specialists. Low-income Australians are more likely to use GPs. I saw this in remote rural healthcare in Burke for Aboriginal patients with complex problems. And again, more recently in my work with asylum seekers. Migrants and refugees tend to miss out on mental health and preventive care also because of the different issues in relation to health literacy and culture and their previous experience of healthcare. So what can we do about this? Addressing comprehensive needs obviously needs different mechanisms for funding than the one we've got at the moment. There's quite a lot of discussion about that. There's been a lot of discussion over the last 4 years. We've made a little bit of progress. Strategies to address disparities for socioeconomically disadvantaged, culturally and linguistically diverse and Indigenous populations include strengthening health literacy responsiveness of services like general practice and cultural competence of the workers within them. The selection and training and deployment of bilingual community health workers or community workers generally from the disadvantaged communities themselves. Promoting greater use of interpreters for cold populations. Providing outreach to facilitate access and care navigation. And telehealth may help reduce barriers to comprehensive care for people living in remote areas, homeless people, and those who may lack transport or other support to attend services. An extreme example of the value of telehealth, in 2019, a network of clinicians provided comprehensive assessment and recommendations, sorry, I'll go backward, for refugees held on Manus Island in Nauru. Based on their medical records and a series of often harrowing telephone consultations, we were able to write reports on their often dire health status, which enabled some of them to be brought to Brisbane for medical care and out of the environment that was harming them. The next principle is coordination. Coordination refers to the key role of primary health care in coordinating access to other services. This is important to ensure that patients are able to enter the appropriate pathways in and out of specialist care, shared care and other services. These have become more important as our health system has become more complex and difficult to navigate and fragmented. Effective coordination across disciplines and services requires not just guidelines and pathways, but also communication between providers, alignment of roles and work practices, and changes to organisational arrangements. And this is difficult. Coordination is a challenge in Australia's very complex system, with different levels of government involved, private, public, and so on. The introduction of team care plans has gone a little way to facilitating coordination. However, while this has improved access to our allied health, it hasn't overcome the barriers and fragmentation between different services. For example, 1 in 4 patients visiting an ED reported inadequate sharing of information back to their usual GP. Low socioeconomic groups, Indigenous Australians and remote Australians have higher rates of preventable hospitalisations, suggesting a level of unmet need for coordinated and preventive care. They're also more likely to be readmitted to the hospital shortly after discharge because of poor communication and the reintegration of care back into the community. And this may be because they don't link back to their GP, don't receive support with a disability at home, or because they don't continue medications. These issues are often most evident when you visit people at home. One example was a patient, that's what I'm referring to, visited by an outreach worker who found that he put all his medications in the takeaway container, put them all there. These are not a day, this is all his medication for a week, and would choose based on colour which ones he took each day. Obviously, the solution is to reduce the complexity and burden to health literacy of various care pathways and transitions in care. But selection and training of bilingual health workers from disadvantaged communities to support people to navigate the health system is another important strategy and one that we're currently researching. Continuity, I'm getting there. Do we need to stand up? Continuity refers to the consistent provision and use of care providers and services across time. This may be relational, where the same provider provides care, allowing the development of relationships and trust, or it may be based on teams and services, or it may be informational, or all three. Evidence for association between relational continuity and health outcomes is really strong, especially for people with chronic conditions. And I saw that particularly in my own practice in many settings. It can be difficult to sustain relational continuity of care in our fragmented system. A quarter of patients access multiple GPs in a year. While there have been efforts to improve informational continuity across primary care, limited progress has been made on sharing information between hospitals and general practices because of policy barriers such as privacy and confidentiality. Low socioeconomic patients receive less continuity of care because of a lack of availability of or demand on their usual GP, fragmentation of care involving multiple providers. This comes at a high price, especially for people who are homeless, have severe mental illness, or multiple health and social problems. Unless great care is taken in their design and function, urgent care centres may help improve access to care in response to acute need, while further undermining low socioeconomic groups' relational continuity of care. Something we need to work on. The key aim of my health record, the diagram of how it's supposed to work, was informational continuity across services. However, while this was a great advance, it's had relatively little impact on coordination of care for disadvantaged groups. This has led to the development of a variety of other information platforms to enable sharing of information between different providers, including our own work on using e-care plans to support patients with cancer or severe mental illness. This requires engagement of people in both services and also overcoming barriers to sharing information that I talked about already. It's not impossible. UK and New Zealand have cracked it. They do it. They share information now between primary care and other services. Why can't we do that here? For patients to engage in care, they need to have access as well, and they may need support to, it's important that they're part of the team. It's not just the healthcare providers. And that support may come from peer or other health workers, community health workers providing support. My Medicare includes a system for enrollment or voluntary registration of patients with general practice linked to some additional Medicare items and blended funding. This is happening as we sit here. However, enrolment in My Medicare may reinforce health inequities unless there is extra support for disadvantaged groups to enrol and engage. In New Zealand, rates of enrolment are currently lower in deprived areas for Maori and for young people. We need to make sure that doesn't happen here. Enrolment may provide an opportunity to identify those patients with lower continuity of care or who may be using the emergency department instead of primary care. However, it can only do so if it's accompanied by active measures to manage the population of the practice and to reach out to those who don't enrol or present. Beyond the practice, information systems need to be established to support and enable safe sharing of clinical information. These are essential to ensure that care is tailored to the needs of disadvantaged and vulnerable groups and to monitor that care is being adequately provided and followed up. Community health workers, again, have been effective in supporting disadvantaged groups to engage with their information systems. Participation is an additional important function. It encompasses not only the responsiveness to needs, comprehensiveness, but in the context of primary healthcare, this includes support for self-management, for shared decision-making between patients and providers at the individual level, and at the organisational level, involvement of patients and communities in decision-making about the service and its development. Despite self-management and shared decision-making being supported by government policy, chronic care strategy, the Australian Commission on Quality and Safety in Healthcare, there's little systematic information about just to what extent consumers actually are participating in primary care. 2018 ABS Health Literacy Survey suggested that most people were actively managing their health, which is great. But when people with asthma were asked how many of them actually had an action plan to manage their asthma, only a third of them did. So clearly we need better information about just to what extent consumers actually are participating. On the health equity side, the uptake and implementation of self-management and shared decision-making is influenced by socioeconomic factors again. Without careful tailoring to needs and language, taking measures to acknowledge and recognise people's agency, and directly targeting barriers to self-management, interventions can actually exacerbate disparities between low and high socioeconomic groups. Many clinicians confound lack of motivation with low health literacy, as both may involve low levels of engagement in their own management. So people who have low health literacy are particularly less likely to ask questions about it. So they can look like they're not interested, and that's a problem. Difficulty communicating in English is obviously a significant barrier to shared decision making. So what can we do about it? There's a need to reverse some of that, to encourage more agency. We need, obviously, interpreters and peer workers and bilingual community health workers to help facilitate self-management and shared decision-making by culturally and linguistically diverse patients. At the organisational level, we've demonstrated the value of engaging disadvantaged communities and people with lived experience in identifying needs and setting priorities and co-designing solutions. So I'm almost there. This is not quite the last slide, but almost. Over the past decade, there's been some significant advances in primary care in Australia, with improvements in the quality and multidisciplinary approach to dealing with chronic conditions. Australian primary care performs around the middle in terms of some of the core functions of primary care in comparison with similar countries. Care plans, practice nurses, access to allied health, and targeted primary health network programs have helped to improve access and provide more comprehensive multidisciplinary team care. And they appear to be applying most where they're needed. That's not to say that there's not room for improvement. However, continuity of care and coordination may actually be getting worse, and because of the fragmentation of services and the continuing barriers to sharing of information and communication, especially between GPs and other health services. Participation in self-management, shared decision-making, planning and co-design may be improving. It's certainly getting more attention. However, it's difficult to know because there's not information particularly on the extent to which it's pursued in primary care. The continuing evolution of the health system in response to changing needs is putting increasing pressure on primary healthcare. It's not just the COVID pandemic that's exhausted our GPs. Despite the development of a plethora of initiatives and services funded to improve access to care, a crisis has emerged in primary healthcare workforce supply and morale. This is in part related to the squeeze in funding on general practice over the past decade. That's most affected those who are vulnerable and disadvantaged and the primary care providers that work with them. We are currently developing and evaluating strategies to address some of the inequities that have emerged. This includes the use of digital tools and community health navigators to improve community continuity and coordination of care, especially in culturally and linguistically diverse people and those with low health literacy. At the organisation and system level, the introduction of enrolment through My Medicare represents a hopeful development, which may strengthen coordination and continuity. However, it will be important to ensure that there is adequate support to ensure that its introduction doesn't impose additional burdens on an already stressed workforce, and as I've already said, to ensure that it addresses the needs of disadvantaged groups. Efforts to improve consumer and community participation, both in clinical care and at the service level, are becoming more sophisticated. Ultimately, this may help primary healthcare to continue to improve and maybe help politicians to see that primary healthcare improvement requires a systems approach, not simply adding additional fragmented services, but building on the core functions of primary healthcare. So what does this all mean? We're not there yet. We're still part way along the journey, but it's worth keeping going. Primary care does allow the health system as a whole to be more efficient, but it also allows it to improve its level of health equity. Thank you. There's some of the people I've worked with that I could grab some pictures of.
Hang on there for a minute. Ian, did you want to make some comments?
Well, thanks, Mark. What a great finale, in a sense, of contribution to the Centre for Primary Health Care and Equity. What's shone for me through this talk was your leadership and innovation and advocacy for primary health care. But most importantly, you spoke about equity, and I could see that sense of we've got to overcome the injustices which we see in the day-to-day practice of medicine and in community health, what I call practical injustices. And what an extraordinary career Mark has had. I know bits of it. In fact, at times I've been scared stiff of Mark and Liz, who's up the back, when they were agitating in southwest Sydney for resident action groups and the like. They were a formidable combination, and no doubt in other environments, in Burke, Vanuatu, Sabah, and other places they've been to, they've been a terrific combination in helping people, in dealing with issues of health, in advocating for primary health care. The Centre for Primary Health Care and Equity is an emblem of what Mark had been trying to achieve through his career. And I think that the work that they do is some of the hardest work that any research group attempts. It's not like being in a laboratory where you handle jars and bottles and microscopes and things. You're dealing with people, sick people, people who are going to become sick. You're dealing with the care providers, the general practitioners, the nurses. All of those people have to be brought together to do research in primary health care. And I think that the Centre for Primary Health Care and Equity has been the pinnacle in Australia of research in primary health care and, of course, in equity. As I said a moment ago, equity is the thing that has shone through the talk that Mark has just given to us. And it's also about practical doing public health. Lots of people do public health. They look into the computer screens and can see the data. The sort of public health that Mark is speaking about is actually the doing public health. It's engaging with people. It's listening to people. It's understanding where they're coming from and trying to produce changes in the environments, as he said, where people live and work. You showed a slide, Mark, which was of the notice in the Prince of Wales Hospital. Now, I've got a similar slide somewhere at home of exactly the same statement at the Bankstown Hospital. And you know, I believed as a young doctor and as a doctor through my life that public health services, public hospitals, those great institutions in Australia, were available to anybody that needed them. I couldn't believe it when I saw that these notices were in the emergency departments of our public hospitals. Shattered. That has changed since, partly due to the advocacy of people working with refugee health. So what a great honour to have had Mark give this terrific lecture in my name. Michael Kidd is over there. He gave an earlier one in my name, and I was honoured by that too. But through our lives, we look up to people. They're usually people older than ourselves. And we think, I would like to model my life on that person. Mark's younger than me, and he's a person I've looked up to, and I've often wished that I could have modelled my life on the sort of life he and Liz have led. So, Mark, what a great contribution you've made. What a great talk you've given to us. I hope people have further access to the slides and the lecture that you've just given. Well done.
Thank you, everyone. Well, that concludes the first part of the morning. So morning tea is just outside in the foyer, but all of those of you who are CPHCE staff, you're not allowed to enjoy morning tea yet. You have to go next door into the Tyree room, up towards the stairs where we're going to do some photos. So we'll be coming back at, in 45 minutes. We'll be back here again for the second part of the session. Thank you.